introduce Dr. Kyoko Ono MATSUI, who is one of the leading ophthalmologists in the field of myopia, and she's going to talk to us about the complications of pathologic myopia.
Thank you very much for a great introduction. Most of myopic patients maintain good corrected vision. However, pathologic myopia is a major cause of blindness. According to this review, pathologic myopia was ranked as the second to fifth most common cause of blindness in the white populations, and was the most common cause in the Chinese study as well as in the Japanese study. Then, what causes the blindness in pathologic myopia? There are three major complications: myopic maculopathy, especially neovascularization, myopic traction maculopathy, and glaucoma or myopic optic neuropathy. And the cause of developing the above complications is eye deformity, characterized by posterior staphyloma. Today, I will focus on myopic maculopathy, especially myopic neovascularization and posterior staphyloma. According to the Meta-PM study group, myopic maculopathy is classified into these 5 categories: 0, no maculopathy; 1, tessellated fundus; 2, diffuse atrophy; 3, patchy atrophy; and 4, macular atrophy. Macular atrophy is almost always related to myopic macular neovascularization. Other lesions like cracks and neovascularization, which occur irrespective of the progression of these 5 categories, are considered plus lesions. And based on this study, pathologic myopia is defined as the eyes having myopic maculopathy equal to or more serious than diffuse atrophy, or eyes having posterior staphyloma. So the development of diffuse atrophy is a gateway to a pathologic myopia. Then, what are OCT features of each lesion? This is diffuse atrophy. This lesion is characterized by extreme thinning of the choroid. Almost the entire choroid disappears, besides sporadically remaining large choroidal vessels. Diffuse atrophy starts from peripapillary in childhood as peripapillary diffuse atrophy, which later progresses to macular diffuse atrophy. Peripapillary atrophy is characterized by abrupt thinning of the peripapillary choroid. The transition from relatively normal choroid around the fovea to almost absent choroid is sudden. And because it's not generalized thinning, circulatory disturbance may not be a cause. But anyway, although the area is different, both peripapillary diffuse atrophy and macular atrophy are characterized by extreme thinning of the choroid. Then patchy atrophy and macular atrophy, they are both well-defined whitish lesions, but the location is different. Patchy atrophy is seen outside the fovea, and macular atrophy is neovascularization related and fovea centered. OCT showed that both lesions were not simply an atrophy, but were characterized by Bruch's membrane defects. And neovascularization-related macular atrophy showed similar appearance to patchy atrophy, but it develops only after neovascularization. And in addition, as I mentioned, the location is different. Macular atrophy is always centered on the fovea and expands circumferentially. In contrast, patchy atrophy develops away from the fovea, and even when it enlarges, it does not enlarge in the direction toward the fovea. Among various lesions of myopic maculopathy, neovascularization is the most common cause of the central vision loss in patients with pathologic myopia. It develops in around 10% of patients with pathologic myopia. Anti-VEGF therapies are currently the first-line therapy for this condition, and ranibizumab and aflibercept has now been approved in Japan, and off-label use of bevacizumab or other anti-agents have been used in other countries. However, not all of the patients become happy. In the patients with neovascularization, new vessels itself regresses by treatment. However, neovascularization does not disappear completely, and eventually macular atrophy develops and enlarges around the regressed new vessels, which worsens the vision in a long term. This patient had neovascularization with small hemorrhage at onset, and 4 years after bevacizumab, neovascularization regressed completely, but macular atrophy develops in 4 years, and the vision has declined. So atrophy can be observed clearly in autofluorescence image. And in this patient as well, there is large CNV surrounded by hemorrhage, but the neovascularization itself has responded to the treatment very well and become a tiny pigmented scar in 6 years. But a large macular atrophy develops and it tends to enlarge, continues to enlarge, and so the vision has declined to 0.08. The next complication is macular retinoschisis, which occurs in 9 to 34% of highly myopic eyes. And natural cause shows that this condition progresses to more serious conditions like macular whole retinal detachment. And this is a classification by Shimada and colleagues, and they classified retinoschisis according to the location and extent of retinoschisis. And this is another classification using wider scan of OCT. And some modified technique of IOL peeling is shown to be useful for this condition, and which is fovea sparing IOL peeling. Usually we remove IOM completely, but we remain the IOM around the fovea to protect the fragile fovea from surgical insult. And in this case, in the bottom left image, high retinoschisis is seen, but with this technique, retinoschisis has gradually resolved in the long term. And finally, we need to remember that glaucoma is one of the most devastating complications of high myopia. But glaucoma is difficult to be diagnosed, sometimes until its advanced stages, because of deformity and tilting of optic disc, and measuring nerve fiber layer thickness as well as ganglion cell layer thickness is difficult. And Humphrey visual field is difficult to interpret because of large conus and myopic maculopathy. And severe deformity is seen in the optic disc in pathologic myopia. The optic disc is no longer circular or oval, very severely deformed. So I'm going to show you this patient. This is a 35-year-old man. Axial length is 30 millimeters, and IOP is almost always low. And this patient has complained of vision decrease, but he has diffuse atrophy, and he has been told that his vision decrease is because of myopic maculopathy. But when he came to our hospital, his visual field is already like this, and IOP is low. And sooner or later, we performed surgery, but in 5 years or so, he completely lost the vision. And glaucoma is overlooked and underdiagnosed in pathologic myopia, even until its advanced terminal stage. But because it develops at a much younger age than non-highly myopic glaucoma, and it is not rare for them to completely lose sight during productive years. So we should advocate always suspect a glaucoma in highly myopic patients. So in conclusion, pathologic myopia is defined as eyes having myopic maculopathy equal to or more serious than diffuse atrophy or having staphylomas. Endovisual therapy and vitrectomy are effective to treat neovascularization and retinoschisis. And glaucoma is common and progressive. However, it's overlooked and underdiagnosed in pathologic myopia. So we use Goldman perimetry regularly. Staphloma is well observed in wide field OCT, and future therapies would be to prevent the progression of staphloma before developing vision-threatening complications. Thank you very much.
Thank you for this enlightening talk.